We have an 11-center consortium right now, which we are trying to expand to 18 centers, and have been really lucky to work with Doris Hansen from Moffitt and Survi Sudana from Stanford in organizing all these centers to have this database. So this is all everybody working for free, volunteering. We don't have support for any of this, but all of us have had lots of patients we've treated with CAR-T, and from the beginning we really wanted to see how we can make things better in the real world. So we had about 196 patients from all the centers that were collected. 155 or so actually got infusions. So people came off for different reasons. There were a few patients, about 12, that didn't manufacture. 7 of those we were able to recollect and manufacture again. And then there were a lot of patients that died from disease progression or from infections or something else, right? But out of the 155, 56 patients, we actually saw results in terms of response very similar. So it was 86%. Mind you, most of these patients had gotten, the average was about 407 million cells, which on the KarMMa trial, if you look at the people who got the 450 million cells, the response rate was around the same, 82, 84%. So it was very similar. The progression-free survival was also similar for those patients, about 8.8, 8.9 months. And what we were able to show is that 77% of these patients, however, were not eligible for KarMMa. So unlike the trial, where they had these strict eligibility criteria, our patients had issues with kidney function. They had prior BCMA therapy, which was not allowed on the original trial, and cytopenias, which, for our myeloma patients, relapse refractory, we have a lot of those issues. So to be able to show that it was still safe and efficacious in those patients, I think is pretty amazing, and just tells us that, okay, this should be more applicable than what just the trial says. Again, because it's so complicated and because there's limited slots, we want to make sure we get as many patients to it, but we also want to make sure it's safe for all patients, and I think this has proven that for the majority of our patients, it actually is safe. And then the safety, which was the big thing, was the same. Our CRS rates are very similar and mostly grade 1, maybe a little bit of grade 2. We don't see very much ICANS or neurotoxicity, so it was good to see that in these more patients with comorbidities and performance status that wasn't as good, that the safety was still really comparable.